From the hidden secrets of our backyards to the realities of the third world, we take a raw and real look into the challenges and the pursuits of social justice. Welcome to The Point.
The Point podcast is brought to you by LaPointe.life, offering healthcare, entrepreneurship, and education both domestically and internationally. Visit LaPointe.life to find out how you can get involved.
Did you know that in low-income countries, there's only one doctor for every 10,000 people? Here are some other stats that are going to blow your mind. 50% of people across the globe lack access to essential healthcare. 50%. 99% of maternal deaths happen in developing countries. And each day, 15,000 children die before reaching their 5th birthday. Okay, so all that can feel really depressing. So what's the good news? The good news is that a lot of these statistics can actually be avoided through simple prevention. And that's exactly what our guests today have been working on for years. And not only have they been working at it, but they've actually been successful at it. Dr. Eric Nelson and Molly Clairman and their team have come up with an innovative approach to healthcare in some of the poorest places in the world. They're quite literally saving lives by bridging the gap between the onset of illness and the access to healthcare. There's just a few hours in there, and those are precious moments when a disease can go from bad to deadly. And how are they doing it? Join us today to find out. Molly, why don't we start with you? You are speaking to us from the Dominican Republic right now. Walk us a bit through your personal journey of how you got to be where you are now.
Okay, so I am a research coordinator at University of Florida, working with Eric. This is I think I had my 5th year anniversary yesterday. I'm the director of a series of research studies called ENACT, which stands for Improving Nighttime Access to Care and Treatment. And in the ENACT studies, we're designing, building, and evaluating the MotiMed project, which is a telemedicine and medication delivery service. My background is in public health and actually arrived there through conservation biology. When I first graduated from college, my first job was in conservation biology. And I quickly realized that you needed the buy-in of the people using the natural resources, for them to use them wisely and resourcefully. And usually that buy-in comes from economic reasons or economic motivations, which are closely tied to other sectors like health or education. And so in exploring those ideas, I came across EcoHealth, which is now called One Health, but it's basically, between healthy people and a healthy environment. So I went to get my master's in public health and global environmental health. And then I've spent the past 13 years working in public health, and 11 of those years were with 2 NGOs, health-based NGOs in Haiti. It's kind of random that I ended up from Haiti. I had previously worked in Spanish-speaking countries. And in both those positions, I was mostly tasked with designing, implementing, and evaluating public health programs, mainly in the areas of maternal, child, and reproductive health. And then most recent position, I was there for 4 years, and it was very rewarding and challenging. And we overhauled the whole organization and put a lot of protocols and just a lot of work. But we got to a point of maintenance, and I foresaw myself getting bored if I stayed in that role. So I started looking for other opportunities, and that's when I met Eric. And I was excited about the idea of getting back into research. In the NGO world, there's a lot of superlatives thrown around. So it's extreme poverty or no access to healthcare. But I've always liked statistics and evidence-based, reasoning. So I was excited to get back into research. And then in particular, the proposal that Eric had brought up of this MotiMed's telemedicine and medication delivery service was really interesting to me too, because I have young kids, and accessing healthcare in Haiti is really difficult for many reasons. So when my kids were sick, I would just contact a friend who's a doctor who, I had met through my jobs in public health. And I would explain to them the problem. They would say, okay, well, I think, you have this and you need to go buy this. And so I'd go to the local pharmacy and buy it. And that's basically my own pseudo telemedicine MotiMeds, I was already employing it. So I was okay, this sounds great. And obviously I have more resources than your average Haitian mom. So if I have difficult and I have a fear of going to clinics, then worse for them. So yeah, that's how Eric and I got connected. And then we've been working on designing and building this telemedicine medication delivery service since then.
So cool. I love it. And how old are your kids now?
4 and 6.
Oh, that's great. Busy lady. Yes. And Eric, tell us about you.
My story is different. And Molly and I have unique and complementing skill sets, which I think has been a key part to making this enterprise successful. My background is that I'm a pediatrician. I'm a microbiologist. I deliver pizzas for Round Table Pizza. I'm a part engineer. I did 2 years engineering. So I have a pretty diverse skill set. And I trained in, infectious disease when it comes to like the microbiology side, not the clinical infectious disease side, which is a distinction for physicians, less so for the popular world.
No idea. Yes.
Yeah. Yeah. So I'm a general pediatrician. I'm not a subspecialty infectious disease doctor.
Got it.
The reason why I'm actually a generalist is because I'm really interested in why do the majority of children that die on this planet die of really common things that have low cost, known therapies that are effective. And year in and year out, kids keep dying of common diseases that have low cost therapies that are effective. So the issue is not necessarily the diagnosis or the therapy. The issue really comes down to knowledge and access to healthcare and the associated costs. So I've clinically been driven on that side of things, a more generalist side of things. And, with that becomes the question of, is healthcare a human right? And I believe that's a yes. US is one of those strange places that doesn't have that in its doctrine, but globally, most countries, even poor countries, often have that as a yes. And so then through that, I get to our work as really being founded around human rights and advocacy. So scientifically, I've always been interested in host, pathogen, and environment, that kind of triangle. And I had several dances through medicine and science and found my way to the cholera field. And it's the kind of quintessential model for studying host pathogen and environment relationships. And so I was on a fellowship in Bangladesh, working at a hospital scientifically, but then also with my clinical background, I was working clinically. And it was this space in which we would treat 1,000 to 1,500 cholera patients a day. Untreated cholera has a mortality rate of 20 to 40%. With oral rehydration solution or Pedialyte, mortality rates go down to 0.1 or less than 0.1%. And we could take an admission every 2 to 3 minutes, and then a patient without a distal pulse every 12 to 13 minutes, and have these very low mortality rates. So we had this grant to think about, how do you export that level of expertise and acumen from a place like Bangladesh that does this all the time to a place unexpected, in this case, Port-au-Prince, in a rapid fashion. So we wrote an electronic book. We were supported by and recruited by the US CDC to help join in the response in the fall of 2010, when the cholera outbreak came in the Port-au-Prince after the earthquake. And we had this experience, which was we did a pretty good job with the tools that we had. But every morning there's a queue of patients with moderate to severe dehydration that were in shock because overnight they didn't have access to knowledge and medications. And so, on a very bumpy ride back from Cité Soleil, everyone was kind of ending the day talking on phones. And I was just like, there's got to be a way to use cell phone technology to improve access to care in gaps. These 16 hours when clinics are closed, kids and adults still get sick. And if we delay accessing care, they're going to go from a mild disease to a moderate severe situation, which is costly and also life-threatening. So that was the inspiration in 2010. And I went through residency. And then after residency, I went to the research laboratory and just didn't have the wind in my sails. And I kept thinking about those patients that were dying at home at night from cholera and wanting to address that problem, knowing that in the laboratory with PCR reactions, I wasn't going to solve it. So then I wrote a grant, and that grant was to look deeply into this puzzle piece. And we began bringing in stakeholders that had been marginalized historically. And we conducted a lot of design research in Bangladesh. And, the needs in poor communities in Bangladesh ultimately were very similar to the needs in Haiti. There was a time where Bangladesh destabilized and it was safer to work in Haiti. So then I moved to Florida to pursue this mission in Haiti. And Molly, I don't know if you know this, but on the very first interview trip I had at the University of Florida, I was in Grecier, and I was driving out to the field lab, and there was a wall that had fallen, and there was a sign that said pharmacy on the side of it. And it was a pharmacy that the staff would frequent. And so I just wanted to have a conversation with that pharmacist. And it turned out to be a nurse. And we had cremas on the front porch, and she told me her story. And that what her story was that she sold wedding dresses during the day. And then at night, she would get phone calls from the community up in the mountains with medical problems. And then she had a side room with medications, and she would connect basically a driver with that med and motorcycle meds up to the household, via her cell phone. So organically, MotoMeds not just is happening in Haiti, but it happens all over the world. And what we're trying to do is kind of formalize that model, work with, medical professionals and drivers within communities, and extend care through a natural network that's already, in fact, there.
Yeah, that's so cool. So technically then, MotoMeds started which year?
So we started in September of 2019, but prior to that, we did a formal needs assessment in Haiti. So we interviewed families and healthcare providers about their care seeking behaviors and obstacles.
Mm-hmm.
That started in 2000.
Okay, and something I thought was interesting as I was researching about MotoMeds is that you were mentioning that there's like a bias usually in research, which I had never thought about, where if you're a researcher, you're going into these places to collect data, but the people that you're talking to are usually closest to roads, right? So their access to healthcare or medicine is going to be different than the people who are living very rurally in places like Haiti. Is that correct?
Yeah. So, one of the things that we really strive for is giving a voice to the marginalized. And simply living on a road versus not living on a road means that your voice might end up being marginalized. So in that study that Molly just referenced, we were really keen on healthcare seeking networks. So the social network by which, people access. And another form of marginalization is if you just interview conventional healthcare providers, you might miss a huge part of the healthcare, spectrum, which might be a leaf vendor, it might be an herbalist, it might be a voodoo doctor. And so the study that Molly conducted asked families, in the past month, who do they seek care from? And then she went and sought those providers out, traditional or non-traditional providers, and then interviewed them for generally what was the catchment for their patients, and then who did they refer patients onwards, and really formed a unbiased healthcare network. And the way that she sampled was randomized geospatially, and it was designed to be road independent.
Very cool. And I think it's important for people who maybe haven't experienced a context for places like Haiti is that there's really only a few major roads that go through the country, like literally a few major roads due to the lack of infrastructure. And so we're talking like 10 to 20 like major highways, going through the country. And so it's important to note that like there are so many families who are living how we would consider off the grid, who might not have access to some of these things. So one of the stats that your website also talks about is that there's only 1 to 2 doctors for every 10,000 people. Tell us a bit like about what that means, and what does that mean like as compared to a place like the United States, so we can get some context for that as well.
Well, Molly, has lived and raised a family in Haiti, and knows on a very granular level what it's like to have a kid get sick at night and not be able to, readily access care. So in Haiti, even if there is a doctor, they have to be at the clinic. The clinic has to have power, and they have to have medications in hand. And it's probably going to be a weekday thing than a weekend thing. So even if you have doctors in place, they might not be available. The other thing is that physicians have different levels of comfort. A lot of physicians are not comfortable with children. And so, especially as kids are under 1 year of age, we've experienced some events where physicians, let's say an OBGYN, who's staffing the emergency room at a hospital one night, may actually not want to take care of a child because it's sort of outside the scope. So it's not just, is a doctor available, but then also what's their comfort level, and then what's the infrastructure to support that doctor. Mm-hmm. And I would say that, if my daughter, who's 11 here in Gainesville, Florida, gets sick tonight at 2 a.m, I have two options. I can wait till the morning, miss work, and go in, and the doctor will tell me that my child has a viral cold and I should take Tylenol, give the child Tylenol and give them Pedialyte and move on. Or I can go to the emergency room that night and have, a cost incurred by the system as a whole of, $2,500 to $5,000. There's no in-betweener. And the concept of having a number like we have in Haiti that you can call, get a professional that speaks with you, goes through a triage assessment and plan, and then motorcycle you medications if your child has mild illness. And then if you have moderate illness, that professional will come to your house and examine your child. And then if it's severe, they'll have a recommendation to go to the emergency room. Like, that is an incredibly valuable lifeline that would be useful here in Gainesville. So those gaps exist, rural, urban, all over the US as well. So the model is generalizable globally. And it's almost like Molly and I are faced with this problem right now of what to do with the success we've had. Because we feel like if we simply publish articles and call it a day and share our guidelines, then it's a tragedy.
Can you tell us maybe a story that you have that sticks with you from a parent or a recipient of MotoMeds?
When we first started, as part of the training, I sat in the call center like every night from 6 p.m. to probably like 11 p.m., if not later. And then in the launch of MotoMeds to, I guess, ensure that our protocols were clinically safe and just logistically worked, we sent a nurse to every single household that called us. So we made an assessment and a treatment plan at the call center, and then we would go to the house and a nurse would perform an in-person exam to verify the information we heard over the phone matches what they saw at the bedside. We're relying on, untrained, usually poorly educated parents to give us clinical information. And so they could do it just fine, or they could, be giving us incorrect information, and we're generating, prescribing antibiotics incorrectly. So that was our first study. And so during the training, I went to all of the household visits to facilitate training our employees. So I was there to witness, parents' surprise when we actually showed up. A lot of them were just really weren't sure what to expect. They would hear in the street, either through our advertising or through word of mouth, that there's a service you call at night for healthcare. But a lot of them thought we were a physical location. And so they would ask us, where do we come? And we're like, no, we'll come to you. And then they're like, okay, are you sure? Like, I live far away, or it's dark, or it's night. Not a lot of things happen in Haiti at nighttime because there's no electricity. So, most people go home and go to bed. But if your child's sick, you can't just go to bed. So, like I said, I was able to participate in all these visits, and just the surprise that people had that we actually showed up. They're, surprised that a nurse was there, to come to their house, especially at night. And then that just caused neighbors to come over, and there's what's going on? Why are you receiving this kind of service? And I remember there's a grandmother in the corner of, these are small Haitian houses without electricity. And we're cramming ourselves into the one room house, and we have headlamps and all this a huge bag of materials. So it's very awkward. But this grandmother she was just oh my God, they showed up. And the father was like, I told you they were coming. And the grandmother was like, no, I didn't think anyone went out at night in Haiti. And then she's like, is that a nurse? Is that a real nurse? And the nurse was like, yes, yeah. I'm have my nursing license and everything. And she was just like, oh, we have to tell all of our neighbors about this. That was just like stuck with me. She was just so surprised and shocked and appreciative of it. And then also just seeing all the sick. I mean, there's this one child who I think was maybe like 10 days old and had a like severe skin infection already at that age. And the mom was not a first-time mom, but she wasn't breastfeeding well. And so the child was actually moderately dehydrated. And I think that was the first time I'd ever seen a moderately dehydrated child. And I can't even just imagine like what like a severely dehydrated child would look like. But it was just the education that our nurse was able to provide to the mom, I'm sure saved the child's life.
Wow. Yeah, no, that's powerful. And I love too, like that way you said, like the grandma was surprised, because in the nonprofit world, and especially in places like Haiti, there's been a lot of talk about what these places can do for you, but not always follow through. So being able to create that trust with the community is vital as well.
There's a couple pieces of what Molly shared, which we'll never be able to put into like a graph on a research paper. One is the concept of hope.
Mm.
And if you're a person who literally no one has ever answered the call for help, and you place a call at 1 a.m. because your 3-month-old is having difficulty breathing,
Yeah.
and someone actually picks up the phone, and you live on top of a mountain where there's no paved roads, there's no electricity, there's no address system, and a motorcycle with a nurse on the back of it shows up in the middle of the night to assess your child and provide some pre-emergency care, it is outstanding. And that kind of concept that someone does care, and the concept of hope, it's hard to kind of quantify that when it comes to conversations with donors or conversations with like the US Embassy or USAID. But it's a win for the family, and then also for the staff. It's a morale booster. It's a sense of we can get through a difficult moment in Haiti. And the other thing that's happening is that we chose Haiti for a bunch of reasons, but we felt like if we could make something that was durable for Haiti, it could probably thrive anywhere.
Yes.
So then that test of portability is being had right now in a slum community of Accra, Ghana, and we launched a USAID funded initiative of MotoMeds in Ghana about a month ago. And I think in part because infrastructure is just a little bit better, it caught on from the very first night.
Wow.
And kind of same sense of hope and excitement, and maybe the good things can come out of this world instantly happened from the very first night. And the logistics behind MotoMeds have taken learnings from across the technology industry. I made a study of a food delivery company in Dhaka, which is 28 million people. And this food delivery company has 300 to 500 restaurants that they work with, and they can deliver, food on time and, in less than 2 hours, that's warm and at the right price. And so if you think about those logistics in a city with a very poor address system as well, and you take that mindset of leveraging local drivers to rural Haiti, you can start to piece together the logistics. And then kind of one of the things that we think about the logistics of MotoMeds is, imagine if someone like during the daytime, and it was a super hot day in a community without an address system, formal roads, that person was super hot and they wanted a cold Coca-Cola. And they didn't have it. And they could call up a number, and then that cold Coca-Cola would show up in their hand cold at the right price under 2 hours. That would be amazing. And what MotoMeds has done is really solve that problem. And one of the pieces underneath of MotoMeds is all the technology, after the call comes in on a non-smartphone. What we did was we worked with a not-for-profit called Trek Medics that builds emergency medical response software for places that are low resourced. And their concept was they bring patients in a classical kind of 911 model from a household to a centralized source of resources. And then we asked, could we take your software, flip it upside down, and mobilize resources from a centralized place to households on the same road, but the opposite direction, and get to that household before they have an emergency and do it at under 2 hours, has been our benchmark. And then in the work with, that Molly's led, we now have well over, 1,000. I don't know what the current enrollment is, Molly, but our average time to delivery is about 72 minutes. And as someone who's delivered pizzas in California, I rarely got a pizza delivered in 72 minutes from the time the call first came in.
I mean, to do anything in Haiti under 72 minutes is really impressive, honestly. I used to say
at nighttime.
At night, to do anything after, they always say nothing good happens after 10 p.m. I always said that there should be this reality show and you would literally win $1 million if you could get a gallon of cold milk under 24 hours. Because it was you go to one grocery store and that grocery store would be no, we're closed for the day. And the next one would be our port never came in. And the next one would be we don't have electricity. And the next one would be we don't have change. And so to accomplish something consistently is very impressive. And then to accomplish something in that time frame is even more impressive. Molly, can you tell us a bit about the internal structure? I would love to know how you make all this magic happen.
We have our central call center in Gressier, and it's staffed by 8 nurses and family nurse practitioners. And we have 8 trained MotoMeds delivery drivers in Gressier. And then we have a satellite location in Likai. And we have 6 nurses who work out of their homes there, and 6 delivery drivers in Okai as well. And the service is open from 6 p.m. to 5 a.m. So families can call in and they'll reach one of our nurses in the Gressier call center, and they follow a set of clinical decision support tools that we created, and they're based off of the WHO IMCI guidelines. So that's the Integrated Management for Childhood Illness guidelines. And so those were originally meant for in-person assessments, but we adapted them for telemedicine use. And so basically the nurse will ask the parents a series of questions depending on the child's complaints. So we focus on the most common childhood illnesses. So it's respiratory infection, diarrhea and vomiting, or so dehydration related to those, fever, and then infections like ear infections, urinary tract infections, and skin infections. So the nurse will ask the parent questions about whatever their complaints are, and then they'll use the tools to come up with an assessment. So what's wrong with the child, and then a treatment plan. And if the child is considered to have a mild illness, we will do a delivery alone. And so in Gressier, that means one of the drivers will come to the office. They'll receive a little package of medications, and they have tablets that have instructions for the family how to take the medications, in some cases prepare them. And so those are on videos on the tablet. So we use a dispatch software called Beacon. It was created by an NGO called Trek Medics. And they originally were founded to work in the space of EMS in low resource settings. Because I guess the EMS software that's used in places like the US is prohibitively expensive for low resource settings. So they created their own software. So that's what we use to dispatch drivers. So we're able to alert them about we call them incidents, alert them about the incidents, and then we're able to track the drivers through the different steps. So when they arrive at the office, and then they arrive at the household, and they arrive at their homes. So anyways, the driver comes to the office, picks up the package of medications and their tablet. They usually have general directions on how to arrive near the house. But because there's no address system or roads, they'll get to this meeting point, and then they'll call the family just to hone in on the exact location. Usually they'll say something like the second entrance on the left behind the church, or the red gate, something like that. So they'll go, and then they hand off the medications, and they'll have the parents watch the videos. If there's any questions, they'll call back to the call center for clarification. And so it works similarly in Okai, but the nurses in the call center in Gressier will contact the on-call nurse in Okai, and she has a mobile pharmacy at her house. And so the drivers in Okai will go to the nurse's house, they'll pick up the packet of medications, and they have the tablets, and then they'll do the same thing. They'll go to the family's house. If the child has what's considered a moderate case at the call center, they will also dispatch a nurse who will go to the family's home and perform an exam to make sure that the case doesn't need to be escalated. And then severe cases at any point, whether it's the call center or the household, get referred to the hospital. And we do offer to assist with transportation, but we can't take on the financial cost of the care.
Okay.
And so in all, we have about like 35 employees in Haiti. And then as Eric said earlier, we just launched in Ghana a couple of weeks ago.
Yeah, incredible. And so is that what's next for MotoMeds? Are you hoping to expand within Haiti or different countries, or what's next for y'all?
It's a really, I think, important strategic question, because the way we answer that question could spell success or failure. And we know that after the Okaya expansion, because I was successful and because we were able to deploy in 3 or 4 weeks, right after the earthquake, and basically deliver MotoMeds in as other partners were pulling out after the acute earthquake response, because we were able to deploy effectively in that short time frame, we know the hub and spoke model for MotoMeds could scale nationally in Haiti pretty easily. And right now we're covering somewhere between kind of 5 and 8% of the total population of Haiti, which just shocks me. And, the per call night is not huge, because you only call when you really need to call, and we don't get that many off-target calls. So I have a personal commitment to Haiti, and I would like to nationalize MotoMeds. From a financial perspective, we have a distributed model financially for MotoMeds, and that has a huge amount of cost savings. So if you think about a staff of 28 or 30 in that range and a nightly on-call call center, the Haitian expenditures are around $80,000 a year. So if you multiply that by 10-ish, we'll say, or 15-ish, you get to, $500,000, $750,000 a year to fund an entire country, 10 million people with nighttime access to healthcare for kids under 10. And Haiti is about the same size as Sweden, which I have to remind myself because it's an important kind of point of comparison. So that seemed like a tiny amount of money in my mind to have such a huge impact on those 16 hours of the day when families don't have access to care. So there's a pathway to nationalize in Haiti if money would allow. We work in partnership with the nursing school, with the State University of Haiti and their medical school, and the Ministry of Health. But because the government's been unstable, we've been, to the side of the Ministry of Health. In terms of like a global expansion, we're doing that test case in Ghana. And to get to a global expansion, we're not going to be implementing partners. We're going to be consultants. So Haiti and Ghana are kind of like test kitchens that figure out how to create a package that then other ministries, other NGOs, other partners around the world could take off the shelf and be like, okay, I need to customize this a little bit, but it's pretty well built. Let's deploy it in South Africa, Nepal, Zimbabwe. And to do that, our team and other aspects of our work does a lot of software development. So we've been digitizing our clinical guidelines to make for scalability. And when Molly was talking about guidelines before, it has to be really clear that the World Health Organization does not have a pediatric telemedicine guideline. And so one of the things that we're delivering with those paired studies between what you hear on the phone and what you see at the bedside is using that bedside exam as a reference standard to basically validate the call center guidelines. So that's a huge win. And then if we digitize that, it becomes a win for a much larger kind of sense of the community. So, from a financial perspective, I hate the question of, is MotoMeds going to be financially sustainable? And if our goal is to get healthcare access to marginalized populations, it'll never be sustainable, because you're never going to have a fee for service model in which that family is going to pay for all the expenditures of that delivery. The other thing is that if you're working in unstable settings, the government might not have the funds, the bankroll, the enterprise. So it's always going to be probably a 3-partner situation of some sort of foreign partner, government partner, and then the family. And in Ghana, the service is free because it's under the wing of the Ministry of Health that by their constitution offers free care. In Haiti, there's a great risk of causing harm with MotoMeds if it was free. So we charge $5 approximately for the delivery that covers the cost of meds and the motorcycle. It goes on a sliding scale to 0 if the family can't pay. But the idea is that we put a value on the delivery so that it's respected in the community. But then there's two other key things that happen. The first is that our daytime providers are critical to MotiMeds because we're a bridge to the daytime. And if we undercut the daytime providers that charge, then we'll have conflict and we'll break that trust. The other thing is if we have a free service at night, the daytime patients that get sick might say, I'm not going to pay during the day. I'm going to wait till the night where the person comes to my household and I get free meds. It sounds great.
Right.
So we can actually cause harm by incentivizing families to delay to seek care. So we have understood the financial structure. We've published on a cost effectiveness analysis from disability adjusted life years, as it's called. It's kind of the currency in public health. MotiMeds is incredibly effective. From like a per dollar approach, I like to think about each case costing about $22.
Okay.
$5 is covered by the patient, and then the $17 is covered by some other funding system. And so when people donate money to MotiMeds, I encourage them to do it in units of $22 because that's a child in a night that's going to have their phone call for help answered, and there's going to be ripple effects beyond the amoxicillin and the oral rehydration solution that they get. So I would say our goals are nationalization in Haiti, digitizing our guidelines for deployment globally, and utilizing our Ghana test kitchen and our Haiti test kitchen to design and iterate the model so then it can scale through other implementation partners globally.
Mm-hmm. Molly, did you have anything to add to that?
Just when Eric refers to implementation partners, like community health worker programs have gotten like really popular, and we're doing like something very similar. It's just at nighttime. And so you can imagine a community health worker program just taking this on at nighttime, and then now they're covering like, the 24 hours a day. And then also when Eric was talking about cost, when you think about like the cost of emergency care, that's what the objective of MotiMeds is to treat children early so that their illnesses don't develop into emergency illnesses, which are prohibitively expensive for many people to treat. And sometimes it's not accessible.
And part of that analysis that Molly's done is that if a family goes to a hospital in Haiti, it might result in a 1 or 2 month cost of their total, salary for 1 or 2 months might go in the pay for that, couple day hospital admission. So it's hugely expensive to a family to go to the hospital. And we respect that because another kind of unintended negative consequence is if we're too conservative clinically and we route too many cases to the hospital and bypass MotiMeds, then we're going to inappropriately financially harm families. So part of the tuning of our clinical guideline is that risk assessment of is the case mild, moderate, severe. And we've learned that telemedicine and medication delivery cannot exist unless you have an in-person nurse option for those moderate cases to triage them as needing to go to the hospital or maybe being able to de-escalate them and work only at the household. That's a key piece that I don't think is really appreciated in telemedicine, but it's the pathway to safe and effective and cost-effective care.
That makes sense. Okay, so people want to get in touch with you. They can go to motomeds.org, MOTOMEDS.org. And is there any other way you'd like them to reach out to you?
They can send us an email.
What's your email?
My problem is I'm too accessible. It's Eric, eric.nelson@ufl.edu. And Molly's also accessible by email.
It's mklarman@ufl.edu.
Awesome. And is there any last words of either encouragement or stories or any information that you think is important that we get out?
The message I want to get out is that it's probably a once in a lifetime opportunity that something like MotiMeds waltzes by that could have both local and just global impact that I think can sit at equal impact as like oral rehydration solution because access to care and those barriers is probably the most pressing healthcare problem that exists. And this is a portal to do that. So, why I might cry or get frustrated because through the struggle of many people, there's probably 100 people that's been associated with MotoMeds. We've all been working hard to deliver this gift.
Yeah.
Now we're terrified that it's going to drop on the ground. And so that kind of helping hand from people outside academia that have that experience and that expertise on how to, convey it to the world. That's what we're desperate to do next.
Yeah, I appreciate that. And I think something that's important to note as well is there's a lot of nonprofits. I mean, I can speak personally to Haiti, right? They call it like what was it called? The
NGO capital of the world.
Yes, there was like 10,000 nonprofits per capita or something. But there's very few nonprofits that have done research, that like have collected data, that have like, do you know what I'm saying? Like, I think sometimes in the nonprofit world, it can be a lot of ooey gooey feely things, which is fine, but there isn't data to back up what is happening. And so that's something I really respect about what you guys are doing too, is you took the time to do that and to do it well. And so I'm really just impressed by what you were doing. And as I mentioned, like as a mother, like I can't tell you like how many times I've called. I didn't even know my pediatrician had, evening call line. And there's been times where I'm just like in tears, like I'm a new mom. I don't know what to do. And just by having somebody to calm you down and just say, yeah, give them some Tylenol or this or that can be just, oh my gosh, it's absolutely life-changing. So the other thing I'll say too is like for people who aren't familiar with the context of Haiti, access to care is so difficult. And as Molly mentioned, even for somebody, like myself, who is a white person who has a privilege and is treated different in the systems of Haiti. Like there were times where I would have to go to hospitals with people just so they'd be seen. So there is a lack of care. There's a lack of respect in some of the context. So to be able to have MotoMeds to get people connected with what they need is absolutely incredible.
I wanted to clarify just one piece, which is that MotoMeds currently is not an entity. It's basically the brand, the name that we share, the story of. And we're really hoping that in the coming year that MotoMeds actually graduates itself out of academia and actually becomes an entity of some sort. And currently, MotoMeds has been very graciously hosted by the University of Florida and the Emerging Pathogens Institute that we work at. And with that becomes some really important oversight from an ethical review board at the University of Florida, the ethical review board at the Ministry of Health in Haiti. And it provides a lot of really robust oversight to make it real and trusted.
It's very important to note. Molly, did you have any last words that you wanted to share with us?
Just like on a personal note, in Haiti, my family was a frequent MotoMeds user. And here in the Dominican Republic, there's no MotoMeds. And when the kid's infection, and I had to call Eric because I didn't know what to do.
I feel that. That goes back to what you were talking about earlier. Is like you said, like we didn't necessarily have like access to healthcare either, even with our privilege. So I remember just WebMDing a lot of things and just be like, I probably need this or that, which is usually an antibiotic.
I would say, another principle at MotoMeds is keep it simple. And that's really, really hard to do. And Molly's been a great advocate and just very smart on how to keep things simple. And I think some of that draws on her experience living in Haiti and just knowing the dangers of complexity. And so from our clinical guidelines to the whole workflow, it is lean. And we don't try to solve everything with MotoMeds. We have a guideline that will accommodate for about 90 or 95% of our cases. But then that 5 or 10% that they don't work, we have a call system to get to a physician that's on call overnight. And that allows MotoMeds, I think, to be effective because it's those edge cases. There's exceptions you can get bogged down in, and you can create systems that just get too complicated. So keeping it simple is a guiding principle at MotoMeds.
Yeah, absolutely. And as you mentioned earlier too, because you don't know what the environment is going to bring you. So there's lots of moving pieces with the lack of infrastructure, political instability, natural disasters. There's a lot of moving pieces. So you can get in touch with MotoMeds at motomeds.org. That's MotoMeds.org. And then you can get in touch with Eric or Molly at mklrman@ufl.edu or Eric Nelson at eric.nelson@ufl.edu. I'll be sure to include those in the show notes as well at lapointe.life. Be sure to follow us on Instagram and Facebook at lapointe.life to stay tuned for future podcasts. Thank you so much for your time and joining us today. And until next time, keep on fighting for justice.